And we're going to talk about fentanyl, right? That's really the idea. I'm going to go through the epidemiology piece relatively quickly. I think a lot of the slides are here for reference because I want to get to, as Chris Alleman was saying, kind of the heart of the matter, which is how do we do things? What do we do? So that's really what I'm going to hopefully try to get to pretty quickly. So when we talk about epidemiology, the key thing again that I want to highlight in this slide, I know many of you have probably seen this slide before. I know we've used this in other topics and actually gone into it in more detail, is that we are currently very much, and I think all of us know this just from being clinicians, being community members, very much in this wave, kind of the third wave of the opioid epidemic, which is really driven, the overdose mortalities are driven by illicitly manufactured synthetic opioids, namely illicit fentanyl and its analogs. And those mortalities continue to rise, right? This was released in 2021, end of 2021, by the CDC, showing that, in the year leading up to that point, United States hit an all-time high ever in terms of recorded overdose mortalities, topping over 100,000. Right. And there was an increase, as you can see, of almost 30%, which is dramatic. And this was largely driven by opioids. And when you talk about what type of opioids drove this, again, unsurprisingly, it was synthetic opioids, causing 64% of all drug overdose deaths, which is up a staggering 50% from the previous year. And oftentimes methamphetamine and psychostimulants, we're also seeing more and more, and often the two being used together. So I think this is why it's important, right? That once the fentanyl came, everything changed. I mean, I know many of us like to talk about, we thought we knew exactly what we were doing. And this has been a humbling experience, I think, for many providers, many clinicians, where fentanyl has changed everything. And we're once again back to the drawing board. How do we address this? How do we treat this? The way we were doing things just hasn't been working. And when we talk about fentanyl, that also came in waves. First, starting with what was called fentanyl adulterated or substituted heroin, or FASH. That was marketed as heroin, but of course, because it had fentanyl in it, it was a lot stronger, right? And it was illicitly manufactured. And we largely started seeing it early on, not in the West Coast or Western United States. This green line is the Western United States. And you can see that even through the middle of 2017, we're maybe just starting to see a little uptick, in reported fentanyl use. But you can see that where it was really prevalent at that point was the Northeast, right? Places like New Hampshire, for example, received a lot of attention. The Midwest, as well as the South, especially the Southeast. But the West was really kind of hanging in there, wasn't really doing much. And this is another study showing the same. The darker the color, the more prevalent fentanyl was at that point. And this is 2016, and you can see that much of the Western United States is shaded pretty light, with the example of Texas, California, but most of it is not there. But then came these illicit fentanyl pills, right? These blue pills that we're seeing, and that changed everything. I know we started seeing them first about in New Mexico, maybe even 4 years ago, a little over 4 years ago. And since then, now, as many of you know from your patients, this is all we see. We do not see any other opioids, at least here in my clinic. A lot of my patients say they cannot even find, we cannot even find heroin. What they find is illicit fentanyl being marketed as these blue oxycodone tablets, and that's what our patients are largely using. And as I alluded to it before, like, this has changed everything, right? We don't really know what we're doing anymore. It's presented a lot of clinical challenges. And I think in order to stay ahead or to play catch up for that matter, we really need a comprehensive solution, including things like supply reduction, demand reduction, right? Prevention efforts, upstream stuff like addressing adverse childhood experiences, working on building healthy communities, right? I think all of those things can play into demand reductions, proper screening and brief interventions, maybe supply reduction, matter of policy, partnering with law enforcement, first responders, things like treatment, right? Of course, which we focus on here in this echo, and then harm reduction, fentanyl test strips, naloxone distribution, and really this idea that goes well beyond the topic of this conversation or even this entire echo series is how do we build healthy, resilient communities? How do we help create communities that support each other? I think that's a huge part of that comprehensive solution. And I think we have a long way to go for that. So some general things, focusing on the treatment piece, expect the unexpected, remain curious. And we don't really have any good ways to do point of care testing for fentanyl. So I think it's reasonable to think that, if we don't know, at least here in New Mexico at this point in February 2023, expect fentanyl. That if someone isn't sure what they're using, if it's certainly coming from street sources, chances are there's fentanyl involved. And we have to work with that assumption. In terms of how well do treatments work, I start with this. I mean, I think there is often this idea that naloxone does not work. It does work, although it may occasionally require multiple doses. I was looking at this data recently from Bernie Living, from the Overdose Prevention Office. And he seemed, according to the data he had seen in New Mexico, certainly under 12 milligrams, and very often under 8 milligrams of naloxone was effective, in terms of at least acutely reversing overdose. But that being said, a really important point to highlight that if we're talking to our patients, if we're talking to community members, family members about harm reduction, really important to give the message that even if we reverse the overdose through naloxone administration, it is essential to call 911. New Mexico does have Good Samaritan laws, which does protect the individual in many cases who's calling 911, and the person needs definitive treatment that our first responder professional colleagues can provide, because otherwise the naloxone overdose reversal may be short-lived and the overdose may come back. So if we look at how well do treatments work, how well they work, putting it all together, and thank you, Dr. Warwick, he just put in a paper in naloxone dosing after opioid overdose. Yes, thank you. Good resource there. Is in general, our medications, especially buprenorphine and methadone, work about equally well for people who have been using heroin as they do for people who have been using illicit fentanyl, including reductions in mortality. So they seem to work. We don't really have a lot of data on naltrexone, which is, of course, our third big FDA-approved treatment for opioid use disorders. There is very little data, and induction onto naltrexone may be especially difficult and may require more frequent dosing of the injectable long-acting naltrexone, which a lot of pharmacies are not going to approve. So I think naltrexone has lagged behind in the data, but from the early data, methadone and buprenorphine seem to work well. They work well as long as, and again, we've kind of talked about naloxone overdose reversal, as long as we can deal with the issue of precipitated withdrawals, right? Which was essentially at the heart of the question that Chris Alleman asked earlier, that how do we safely get people who've been using illicit fentanyl onto buprenorphine without leading to a withdrawal phenomenon? It's actually been debated. Why does this happen, right? Why do we get more precipitated withdrawal? Because we don't really see it in clinical studies. So for example, they've done clinical trials where someone's treated with the fentanyl patch for their chronic pain. And in clinical settings or clinical trial research settings, the patch is removed and it's replaced with a transdermal buprenorphine patch. And when that happens, people don't generally get precipitated withdrawals, right? So it's been debated. And I think the two theories that have emerged about why we get these precipitated withdrawals, one is that especially with chronic use, there is this reduced renal clearance of fentanyl. So it may be staying in the system longer than what the half-life might suggest. And another reason that's probably happening is that fentanyl is highly lipophilic. So it's stored in tissue and kind of gradually released in waves. So again, people may be getting these gradual release from tissue, making it more long-acting over time. And I think the third thing, which is not listed here, but at least comes to my mind, is that we don't really know what people are taking, right? When people take illicit fentanyl, is it fentanyl itself? Is it some other analogs of fentanyl, which work similarly, but maybe more potent, maybe more long-acting? I don't know, right? So I think that's a big, unless we're testing every seized sample, we really have little reason to know. And I think that adds another layer of uncertainty. So how do we approach it? So I think I'm going to start with just an algorithm. At least in the outpatient setting for us at ASAP, a majority of our patients are taking the microdose approach. And I start that by saying that what we used to do, right? The traditional, if you take the buprenorphine course, the waiver is gone, but the course is still around. And if you take the buprenorphine waiver course, what they tell you is to wait until the patient is in mild to moderate withdrawal. With fentanyl, they recommend moderate withdrawal. In other words, the COW score of 13 or greater. Then you start with a 2 or 4 milligram dose of buprenorphine. Then you wait 2 hours. And if that's not enough, the patient is still withdrawing, you give another 2 or 4. And on day 1, you try to get people up to 8 milligrams. I guarantee that with most people who are using illicit fentanyl, if you tried that approach, they're going to leave your office screaming. Or if they're doing it at home, they're going to stop taking the buprenorphine and go and do whatever they need to do to come out of withdrawals, because that approach is neither here nor there. I think someone in this Echo forum, was it last week or 2 weeks ago, said that we need to either whisper or shout in the age of fentanyl. So I don't remember who said it, but someone said it. Yeah, and Dr. Boric said, my patients relapse. Yes, so our traditional approach of starting buprenorphine is not very useful in 2023. We need to whisper or shout. Whoever it was, please identify yourself. Whoever shared that beautiful little quote, I like it. So our microdose approach is our whisper approach, right? And I'm using it a lot in our outpatients. So I'm using it in patients who come to me saying, I am too scared to go into withdrawals. I am not able to stop using fentanyl. Can you still help me get onto buprenorphine without me having to go into withdrawals? Well, microdose approach may be appropriate for them, right? And the idea behind it is that the big difference is that we don't tell the patients to stop using their illicit fentanyl. We tell them to keep using it, keep taking your illicit fentanyl, and now we're going to start adding in tiny doses of buprenorphine. And buprenorphine has that high affinity for the mu opioid receptor. So each day, as we gradually increase the dose of buprenorphine, it's going to displace a tiny amount of fentanyl and take its place. And by about a week or so, although the patient has continued to take illicit fentanyl, because we've been gradually escalating the dose of buprenorphine, in about a week or so, the buprenorphine has essentially occupied all the mu opioid receptors. The buprenorphine has done the cross-tapering for us, and the patient has switched over to buprenorphine with relatively low levels of discomfort. That's really the idea. So the big difference is this, that patients can continue their full mu receptor agonists, whether they're illicit or prescribed. And the buprenorphine basically outcompetes the full agonist and takes over. And we don't need to cross taper down the full agonist as we do this. Buprenorphine does the taper for you. That being said, I do tell my patients, and many protocols recommend reducing the full agonist as much as tolerated. So I will tell the patients, start cutting down on your fentanyl as much as you can as you start building up the buprenorphine, but you don't have to do it. So I'll give a quick case to discuss this. This is a 61-year-old male, long history of opioid use disorder, was interested in buprenorphine treatment, had no other substance use disorders, but was extremely afraid of precipitated withdrawals. And we carried out a successful transition using what's called a modified Bernese method. So this was the schedule that we use. This is kind of the classic schedule that we tell patients, right? Day 1, you start with 0.5 milligram once a day. So you can see how low the doses are. Then day 2, you go to 0.5 milligram twice a day. Day 3, 1 milligram twice a day. Day 4, 2 milligrams twice a day. And you gradually build up to 12 milligrams by day 7. And we tell patients to jump off, in other words, stop using the other opioids on day 7. And on day 8, for this patient and for many patients, I would build up to 16 milligrams, and day 9, if needed, 20 or 24 milligrams to really get them to that high dose, which many patients are needing. We used to say that most people on buprenorphine do fine between 12 and 16 milligrams of maintenance dose, but that's changed because of illicit fentanyl, people are coming to us with these high baseline levels of tolerance. And some of the early studies, sure enough, and our clinical experience is showing that patients do better if we get them up to 24 milligrams early to control those cravings and withdrawals. And right when they jump off of the other opioids, the other practical tip is don't be afraid to use comfort medications. I will prescribe liberally comfort medications, clonidine for, kind of the autonomic instability, maybe some ondansetron for nausea, maybe some trazodone for insomnia, maybe ibuprofen or acetaminophen, or maybe even something like methocarbamol for joint aches. So I will use those comfort meds to help the patient just complete this transition. But that's the idea. Then there's this in-between low-dose approach, which has been tried more on the inpatient settings. However, people are starting to use it on outpatient settings also, where generally you still have the patient stop. So this is not like a classic microdose where the person can keep taking fentanyl. So I have some patients who are like, I don't want to prolong my misery for a week. I just want to get off of the fentanyl. I want to get onto buprenorphine, but I want it to be gentle. And that's when I've used this approach, where you do have them stop using fentanyl. We give them comfort meds until their dose, until they're in moderate withdrawals, really. And then they start with 1 or 2 milligrams every couple of hours to gradually build up the dose, with the idea of getting up to 8 milligrams twice a day by day 2. And again, the goal being on third day, I may go up to 24 milligrams if needed. And there was one case series from a couple of years ago that found this approach to be tolerable in an inpatient setting. So some pearls, any microdosing protocol can work. There are lots of them. Sometimes people will use a Butrans patch as a bridge, or maybe the buccal formulations for a bridge. You can do those, but generally, legally you might be in shaky ground using something like that that's approved only for chronic pain treatment, unless the patient also has chronic pain. But you can do it. Be flexible. Use comfort medications aggressively. And having that strong therapeutic alliance, educating the patient, empowering the patient, and staying in contact with them can really help. But here is the big challenge, right? And this is a 36-year-old female that we had, history of opioid use disorder, had been taking fentanyl, worked in a professional capacity. We tried the microdose approach, but she could never switch over. She could never jump off of the fentanyl. And we attempted outpatient microdose initiation with no response for several weeks. And eventually the patient was lost to care, right? That's, I think, the challenge. So that brings us to the macrodose approach, the shout approach, right? And this approach I use in patients who are saying, I can do this, I want to do it quickly, or patients who come to see me and they're already withdrawing. They're already in withdrawals. So the idea there is that we're shouting, we're giving aggressively enough buprenorphine quickly to overcome any withdrawals, whether they're precipitated or protracted. What do I mean by that? So I think that, everyone's talking about precipitated withdrawals with buprenorphine. And certainly that's happening. We have patients who come in and we think that they're in more withdrawals than they are. So we give them buprenorphine and they go into precipitated withdrawals. I think the other reason precipitated withdrawals are becoming more common is that at least I'm seeing more patients who are co-using methamphetamine and fentanyl. So they may be withdrawing from fentanyl, but maybe when I see them, they're intoxicated on methamphetamine, right? So they're anxious, they're restless, their pupils are dilated because of that methamphetamine intoxication. It's kind of a mixed picture, but that artificially drives up their cow's withdrawal scale. So we think they're in withdrawals, we give them buprenorphine, and they go into precipitated withdrawals, right? But just as much, I've also seen people having protracted withdrawals because we're so scared of precipitated withdrawals that we're not aggressive enough. The one example that always comes to my mind is a patient I saw at ASAP who had seen an outpatient provider, was given instructions to start buprenorphine once they were in moderate to severe withdrawals from their illicit fentanyl, and start just that way it recommends in the buprenorphine course. Start with no more than 4 milligrams, wait 2 hours, then take 4 milligrams. Patient followed that faithfully, but the buprenorphine dose just was not enough. And by the time 4 hours that elapsed, the patient was in so much withdrawals that they wound up in the ER. And from the ER, they got referred to us, and we carried out an initiation with them using a kind of a macro dose approach because they were already withdrawing. Right? So here we're shouting to achieve high blood levels, to get over the discomfort, and also to provide the blocking effects of buprenorphine. So in outpatient settings, so again, we want to make sure until they're withdrawing, we want to make sure they're at least in moderate withdrawals, cows of 13 to 15, and then look how aggressively we can go. 8 milligrams, every 30 minutes if needed, as long as they tolerate it, until a dose of 24 or even 32 milligrams is reached. So within a couple of hours, we sometimes can get these folks up to 32 milligrams. I know there are people also recommending going much higher than that with a macro dose approach. I mean, I've seen people go in the 50 and 60 milligram range. Caveat, I have not done that in the outpatient setting. I have only gone up to 32 milligrams. Inpatient settings is a different story. You can do all kinds of stuff, right? Go much higher on the buprenorphine dose, combine it with other medications like benzodiazepines or even ketamine, right? There are things you can do, temporize with morphine, but outpatient, generally, the most I've gone is 32. And then if you have injectable buprenorphine available, then you can actually give them, even on day one, an injectable buprenorphine, 300 milligrams Sublocade, to achieve even higher blood levels. Practically, you can't really do that because you have to order the Sublocade specific for a patient from a specialty pharmacy. That's going to require prior authorization. So it's going to be pretty unlikely that you're going to be able to do this. But certainly this has been done in research settings, and we've been able to do it at least once by some stroke of luck, where the patient just happened to have a Sublocade injection in their name sitting around at our clinic, right? But you can, but if you have that option, that's another option. And that's exactly what this is looking at. This was a study that's now been published by Mariani out of Columbia University, where these are all people using illicit fentanyl. They waited until they were in moderate withdrawals. Then they give them buprenorphine up to 24 milligrams, followed by the 300 milligram Sublocade injection, and followed them, and everyone did really well. You can see these cow scores, right? Anything under 8, anything under 8 is minimal withdrawals, and everyone here, no one really had withdrawals, even going over 8 over the next several days of follow-up. So we were able to do this once. It was a 46-year-old female, long history of opioid use disorder, had been taking up to 50 fentanyl-containing tablets daily, snorting, injecting. She was seen at the care campus, but left before ever getting her first dose of buprenorphine because, quote, I was just kicking too hard. They weren't doing anything. She had failed microdose initiation. She had failed traditional initiations. She was not a candidate for methadone because of prolonged QTC. So she said, let's go for a macrodose initiation. And it just so happened that we had a Sublocade injection under her name sitting around because she had opted for it before. We had gotten the injection and she had never followed up. So we had an injection, right? So basically, I ordered 3 8 milligram buprenorphine strips, told her to start at home after waiting 12 hours. And once her subjective opioid withdrawal scale was over 20, so she actually took 2 doses, 1 dose at 4 milligram, 1 dose at about 7 milligrams, and came to the clinic. Her cows was 6 at presentation. I gave her a Sublocade injection, and she did just fine. Her cows was 4 after 1 hour, and she's now maintained on Sublocade 300 milligrams every 4 weeks, right? So I think we're going to see, and going back to something Chris Alleman was saying, we're going to see the Sublocade injection starting to play a bigger and bigger role, especially if the rules around it change and we're just ordered to have it in stock. And some of the, patient-specific and specialty pharmacy things are, maybe changed. But without that, if someone's already withdrawing, don't be afraid to build up the dose. I routinely will go up, if I take this approach, up to 32 milligrams, even in an outpatient setting. And I know some people are going even higher. I just have not done it before. So I will stop here.